All right, it is a total pleasure to be here today. And to get things started with us, what I'm going to ask you to do is actually just sit for a moment and think. I want you to think about a time when you were in the hospital recently and you were caring for a patient. And you were caring for a patient with at least one other person. And let's be honest, in healthcare these days, that's basically all of the patients that we look after. When you're thinking about a patient that you've seen recently, I want you to think about what was hard and what actually worked well. So I'll just give you about 30 seconds to think of a patient that you've recently cared for. So as we talk today, you can keep that patient in your mind and we'll come back to them. I'll tell you about patients that I look after frequently. As an emergency medicine registrar, I care for trauma patients on a regular basis. Sometimes I'm a part of the trauma team. Sometimes I'm actually the person leading the trauma team. A pretty common, pretty typical case for us would be a 40-year-old man who's riding his motorcycle down the M1 when he unfortunately hit the barrier. By the time paramedics got to him, he had obvious injuries to the left leg, to his abdomen, to his chest, and to his head. He was GCS 15 on scene, and so he was intubated. They were about 10 minutes out. When the patient finally arrived, this is what our trauma bay looks like. It's a bit chaotic, lots of people trying to care for this man. When we think about the people in this room, this is really actually what we're seeing. We're seeing all types of physicians and different allied health professionals working together. How do we make sense of this? How do we ensure that all of these people are doing the right things to get this patient the care that he needs? Well, typically in medicine, what we've done is we've separated our training and our thoughts about this patient into some silos. And this is actually a nice way to think about it. We've got the airway doctor who's going to be looking after the airway. We've got the surgeons who are going to be wondering about the belly. The neurosurgeons are trying to figure out if there's a bleed in the head. This makes sense. But unfortunately, or perhaps just our reality, is that care is delivered much more like this. The patient experiences their journey through the hospital as being suspended in this web. The decisions, the communication between all of these different care providers suspends the patient in a way that we hope that they'll get what they need. This is a pretty precarious position to be. And what we're going to be thinking about today is how we can strengthen this web, how we can make this web as strong as possible so that that patient doesn't fall through. Now, this is the type of web that I've been thinking about this whole year. I've been thinking about the different folks that are involved in trauma care, but really these webs exist for all of the patients that we see. There might be a patient who's had a seizure recently. There may be neurologists involved. There may be neurosurgeons involved. There's certainly outpatient physicians involved, the GP and the patient's family. Or you might be really interested in pediatrics, and there could be a little 3-year-old that has chronic otitis media. That has a whole bunch of different people coordinating their care. No matter what variety of healthcare you're interested in or team you find yourself on, the reality for our patients is that they're suspended by these webs. This is what modern day healthcare really looks like. Overlapping webs of care. It's all a bit confusing. But we're not actually the first industry to have these types of complex issues. And other industries have certainly tried to silo themselves as well. It looks a lot nicer, but this is what we're dealing with. So out of the business world, there's actually been groups of people that have studied care or work that is complex and interdependent and time critical. Airline industries are a bit like this. We need to get people from one destination to another destination with their bags on time. There's other businesses that operate this way as well. So there's one particular business scientist that has thought a lot about how we can coordinate work best together. And through a series of studies, basically what she's found is that there's a number of dimensions of the relationships that we have with people that allow us to coordinate work effectively. These things are pretty simple. They're shared knowledge, but not necessarily medical knowledge, more knowledge about roles of people on the teams, their shared goals, and their mutual respect. So today what we're going to think about is how these different things come into play both in the trauma room, but then how, as doctors in training, we can actually set ourselves up to become relational champions, to become people who are able to coordinate care and work for our patients in an effective way. So certainly in the trauma room, these things come into play. If we think about shared knowledge about roles, in this particular circumstance, knowing what each person in that room can do and is capable of is vitally important. So as the team leader, when I'm looking at this situation, not only do I want to know that the anesthetics doctor can intubate the patient, what I also need to understand is that part of their job is coordinating with theater and making sure that we can get up there. In this type of situation as well, I'm able to understand that the social worker is trying to get in touch with the patient's family and is going to soon provide some important information about who this person is. That allows me to cognitively offload that as a thing that I need to worry about because I know that somebody on my team is taking care of that. I need to know that one of these ED registrars is able to do a fast scan so that I know if this patient's bleeding. And each of these other groups of people need to have an understanding of what other people are able to do. Now, I understand that you're not necessarily the ones leading a trauma right now, but let's think about what we can do in our training to ensure that as we find ourselves in these different patient webs, we can be as effective as possible, both now and later in our career. And so I'm going to implore you to think about your time in early training as an opportunity to cross-train. This is Clara Hughes. She's a Canadian long track speed skater, as well as a cyclist. She's won Olympic medals in both of these sports. She's basically like the Canadian version of Elise Perry. Both of these women I admire greatly. They're able to cross-train in different sports, and I think that cross-training actually makes them better at those individual sports that they end up competing in. So throughout my training, I've thought a little bit about cross-training and how I can go through my training to understand really what goes on in the hospital and become an expert of what people do. So I've spent a bit of time in surgery, I've spent a bit of time in medicine, I've spent a bit of time in outpatients. This is me with the internal medicine team. We wear pink on Fridays for reasons that are still slightly unclear to me, but I just bought into it. I've spent time learning from different people, so despite my inability to retain any information about hyponatremia, I tried really hard to learn about that from the internal medicine doctors, and I've learned from other POCUS enthusiasts in my time in the hospital. I've learned from some absolute legends, and I've made a point of becoming and staying friends with folks that are doing different types of medicine than I am. This is my best friend who's an internal medicine resident, and I have to say that I've learned more medicine from her than I have most other people. Your time as a junior doctor is your opportunity to cross-train like a total pro. It's not just biding out time on the wards, it's this opportunity to understand how the hospital works, who people are, and how you get patients what they need. Then we need to think about shared goals. So you can imagine that we've got this patient in the trauma bay. This patient has competing priorities. They have a head injury, and the neurosurgeons want to know how bad it is. Does it need to go to theater? When they have a head injury, we want to make sure that the blood pressure stays high so that that brain tissue is perfused. But this patient's also bleeding in the gut, and the general surgeon wants to keep the blood pressure low so that bleeding doesn't happen faster. The general surgeons kind of want to take this patient directly up to theater. The neurosurgeons kind of want to go to the CT scanner. This is often what I feel like in those situations. And it's not just these situations. It's patients on the ward who have competing priorities and competing demands. And I found that there's a simple question that we can ask, and anybody on the team can ask this question. You don't need to be a senior registrar or fellow. It's oftentimes a junior doctor, it's a nurse that asks, what are the priorities for this patient? This is a simple question that makes the team realign for a moment and really sort out what's important. You can ask this simple question of yourself when you're admitting a patient or when you're discharging a patient, but you can also ask it of your seniors and of the teams that you're working on. Now, when we think about mutual respect, this is perhaps the easiest to understand, but the hardest to affect of all of the aspects of relational coordination that we're talking about here. Now, I'm not going to stand here and say that junior doctors or doctors who are in training need to be more respectful, because to be honest, we have more to learn about that from you. There are problems at the top that we need to sort out. And believe me, we're working on it. But I want us to think about what can we do in our training to ensure that we remain as respectful as our colleagues as we can. When we think about mutual respect in this particular situation, it's important that we treat each other politely. So obviously in this type of trauma room, we don't want people yelling at each other. That's not going to end well. But mutual respect is actually a bit more than just being polite. Mutual respect in this environment is actually a fundamental belief and understanding that the people in this room bring value. I certainly understand that I can't take this person to the operating theater. I need a surgeon to help do that. And I understand that their role is important. The way that I communicate and the way that I behave demonstrates that respect. So when we ask people in trauma, what can we do to get better at caring for trauma patients? How can we make this complicated, chaotic situation better? This is the response they give us. So we see that relationships are important. We know that they're important. So what are we going to do in our training to ensure that we behave and we continue to behave in the way that we want to, in a way that will demonstrate respect to our colleagues? It's pretty simple. As you go through your training, I want you to identify people that make you feel like you belong, that make you feel like you're a valued member of the team. And then I want you to model that behavior. These people might be peers. They might be people sitting right next to you. They may be nurses on the ward. They may be registrars that you work with, or they may be the most senior consultants. There will be people that make you feel good. Take a moment to think about why they make you feel good, and then continue to model that behavior as you move forward. So I want you just to take a second and chat with the person next to you. I want you to tell them about somebody that you've come across in medicine. Maybe it's, like I said, a peer. Maybe it's a nurse. Maybe it's a senior colleague. I want you to chat with your neighbor about why they made you feel good and one thing that you might model about their behavior. So just take a minute, chat with your neighbor. All right. So we'll bring the conversation back in here. 10 seconds to wrap up. I want you to continue these conversations. We often talk about people that make us feel down, awful things that have happened, but if we can continue this dialogue about the people that make us feel good, I think that might make us likely to behave like those people moving forward. So now we have this construct to think about how we coordinate our work in the hospital and to think about how as doctors in training, we can become relational champions. We're going to think about shared knowledge, about roles in the hospital. We'll think about shared goals for our patients, and we'll try to figure out how we can continue to demonstrate mutual respect. So I want you to think back to that case that you had at the very beginning, of this talk. And if we go back to those original questions about what was hard, I venture that some of the things that were hard had to do with teams, they had to do with the way that people treated us, they had to do with competing priorities. But sometimes those things work as well. In the patients that you see, when we step into the hospital on Monday, or maybe tomorrow if you're working on Sunday, I want you to continue thinking about shared goals, shared knowledge, and mutual respect. We're going to think about healthcare as this complicated network, and we're going to try to figure out how we can support this web. We can support patients in this web without having them fall through. So as you rotate through different specialties, you're going to cross-train like a total pro. You're going to ask a really simple question of yourselves and of your seniors and of the teams that you work on. You're going to identify and you're going to model behavior that makes you feel like you belong. And when you do those things, eventually what you'll find is that you have these absolutely wondrous moments. These are some of the colleagues that I train with back in Canada. Here we've got an orthopedic registrar, an anesthetics registrar, a general surgical registrar, and one of my colleagues in emergency medicine. This was on one of the busiest nights that I can remember of all of my training. We had trauma after trauma after trauma after trauma come through the emergency department. It could have been chaos, and it was a bit of chaos, but it was also extremely well coordinated, and honestly, it was a bit of fun. We had extreme knowledge about each other's roles because we're friends outside of the hospital, and we've actually done each other's jobs on occasion. Savannah who's on the far left there, was clearly defining priorities for patients as the trauma team leader. But we also felt like we could step up and ask, hey, what are we doing here? What are our goals for this patient? And finally, we just treated each other really nicely. It was a wondrous opportunity for us to care for these trauma patients, to keep them supported in a web, and to feel good while doing it. That night, we were relational champions, and you can be too. Thanks.